Corrective jaw surgery is indicated for patients who have a congenital skeletal and dental malocclusion. And what that means is that those patients from birth were growing in a way that created an asymmetry of their jaws such that orthodontics alone will not allow these patients to have the perfect or complete bite.
I think jaw surgery can be broken down into really two main groups. It's you have a bad bite, right? Your teeth just don't come together, or you have a bad airway, which typically means your airway is too small, your tongue is kind of blocking your airflow at night, and you have obstructive sleep apnea. Those are really the two broad categories.
Our jaws can grow at different rates. Sometimes you'll have mandibular retrognathism, which means a deficient lower jaw, prognathism, which is increased lower jaw, vertical maxillary excess, where the upper jaw is a little bit further grown along. Each patient has a different growth rate, and because of that, we have to tailor each and every surgery that we do to the specific patient.
We'll break it down into which jaw you're operating on. Right, so in the lower jaw, it's called the bilateral sagittal split osteotomy, where we make cuts in the lower jawbone, and we're trying to lengthen it or shorten it or rotate it. We're changing the 3D anatomy of the lower jawbone so we can give the patient a better bite or a better airway. The upper jaw, the procedure is called a Le Fort 1 osteotomy, and there's a couple of variations on how we can do that procedure. But same thing, basically we're taking the teeth in the surrounding jawbone and we separate it from the rest of the face, and now we can move it three-dimensionally and put it in the proper position. So we can move it forward, backward, we can kind of airplane it side to side if we have to, we can fix rotation issues. We can even further make bony cuts into the jaw to widen it or narrow it as needed. So it has a lot of flexibility. We can correct three-dimensional issues through changing the jaws three-dimensionally. We often combine jaw surgery with a chin procedure where we can lengthen the chin, we can shorten the chin, we can modify the anatomy so that it's more balanced and harmonious with the rest of the patient's face.
When individuals are referred to us by our orthodontic colleagues, once again, there's likely a discrepancy between the top and the bottom jaw. The first option is to leave it as it is, but it's important to educate those individuals where they are and what might occur. That may, not will, but may lead to problems with muscles being sore, fatigued, arthritis within joints. You can get attrition or wearing of teeth that are all bearing the load. So there's functional problems that can stem from people who have a bad bite.
Not everybody's a jaw surgery candidate. I mean, a lot of problems can be fixed without surgery, but there are some that absolutely need surgery, and that's where we can step in and help. So a discrepancy between your teeth, right? Your teeth are just too far behind in one jaw or another. They're never going to catch up. Orthodontics can't pull the teeth far enough to match the opposing jaw. They need jaw surgery. Same thing with a small airway. You can't pick the jaws up and kind of move them forward with orthodontics alone. You have to do jaw surgery. You have to lengthen the skeleton themselves to improve the airway and improve the bite and improve the face otherwise.
Ultimately, the orthodontist is responsible for making sure those teeth are nicely aligned. We work in unison and tandem with them to make sure that they have those teeth as most ideally positioned as they can have them, and then obviously the communication back to let us know that they're ready to go.
We work directly with the orthodontist, pre-surgically, perioperatively, and post-surgically to really determine where the bite has to be, not only from a functional but also from an aesthetic standpoint. We work closely with prosthodontists, we work closely with ear, nose, and throat doctors, and we also work closely with your primary care physician just to make sure that all of your care is really focused on you as a whole.
Because of the volume of corrective jaw surgery that our practice does, our anesthesia team sees a lot of corrective jaw surgery patients. Our nurses know how to recover this high volume of corrective jaw surgery patients. We perform surgery digitally on the computer prior to the actual event, and that's what helps us with a little bit more insight into skeletal movements and dental movements as well.
This has been one of the most important parts of corrective jaw surgery in the last 20 years. Virtual surgery planning allows us to take our cone beam CT imaging, which we collect in the office, as well as our intraoral scanning, which replaces the old gooey alginate impression, but the intraoral scan, which is a direct impression of the patient's teeth, as well as a cone beam CT, are sent to our partners, who then merge this data to allow us to have three-dimensional planning capabilities known as virtual surgery planning.
Having the technology, the advanced imaging, allows me to see specific anatomic variations well in advance, so we can mitigate problems before they happen. Right? We're going to know what hardware we're going to use, plates and screws, how we're going to put things together after the surgery well in advance. We can now make customized, specific plates and screws for each patient if we need to, if there's specific anatomic concerns.
We spend a great deal of time with families prior to the surgical procedure to ensure that they have great understanding of what they're getting ready to get into. We spend time discussing the procedure itself, the flow of the day through the surgical facility, whether it be a hospital environment as an outpatient surgery or whether it be in our office. We also are going to spend time thoroughly reviewing post-operative care. In terms of the recovery side of the procedure, I think the biggest thing is to ensure that we are here for them. We have designated team phone numbers, so when surgical intervention is performed, that individual is now home, whether it be day 1, day 3, day 14, day 30. They have direct access to the team that performed the surgical procedure for them.
Post-operatively, expectation-wise, realistically, you're looking at about 5 to 6 weeks of a softer, non-chew diet. We'll work with you usually for the first few weeks just with increasing your mouth opening, increasing function.
Risks are always going to be there. Discomfort's always going to be there, but being able to mitigate that ahead of time is what makes us different.
The recovery after jaw surgery, there's a few limitations, specifically, mainly with diet. Your diet is generally limited to a soft, non-chew diet for about 4 to 6 weeks post-surgically, just to allow the bone to heal in the adequate position. The plates and the screws are strong enough to basically hold the bone where it has to be, but we still want to allow adequate amount of time for the bone to heal into that new position. Pain control is always a factor the first week or so, but generally that will improve. One of the other things during the first few months after jaw surgery is generally there will be some numbness to the lip, on the upper lip and also the lower lip. Generally that resolves a few months after surgery, but it's something that we closely monitor. Post-surgically, given the fact that we do so many of these cases per year, we've got a fantastic and supportive staff that during every post-operative visit we kind of reiterate post-surgical plan, what we're looking for, what our goals are, to kind of get you to that final point where we're moving forward with post-surgical orthodontics at usually about week 5 or 6.